Well, I'm sure honored that you'd take the time to spend the time with me. I've wrestled with healthcare from a patient's perspective in about as many dimensions as you would ever want to. But from an academic perspective, what happened to me is about, 12 years ago maybe. I was just in my office minding my business, studying innovation. And I got visited by Jerry Grossman, who at the time was the CEO of the Tufts New England Medical Center, and Liz Armstrong, who was at the time the director of education at the medical school, with an interesting proposition. And it was, you know, the problems in healthcare at their core are all problems of managing innovation in one way or another. And everybody's been studying healthcare to reach conclusions about healthcare. If at their core there are problems of innovation, maybe you could just put on your lenses on innovation, or your theories like a set of lenses, and examine healthcare from a different perspective. Maybe you can see stuff that others haven't been able to see. So I naively said, gee, this would be fun. And turns out to be just by several orders of magnitude more complicated than anything I've tried to wrap my brain around. But we got to a point a couple of years ago where we weren't ashamed of what we were seeing, and so we published a book called The Innovator's Solution. And those of you who have tried to do these kinds of things, you realize that the publishing of a book is simply a minor milestone along a long stretch of road. And the day after the book is published, you realize much of what needed to be said wasn't said in the book. And so we're just continuing to study this. Just one other thing about me. I had a stroke about last year, and a clot came from somewhere and just lodged itself right here in my brain and killed the portion of my brain where speech is formulated. And just instantly, I was reasonably fluent, and all of a sudden I couldn't say any words. And so for the last year or so, I've been trying to learn how to speak again. What I did was I went out to Logan and got Rosetta Stone for English. And I had a marvelous 5-year-old granddaughter. And so we worked through it together, starting with lesson 1. And she beat the pants off me all the way through. But anyway, so you'll see that I miss words occasionally, and I just apologize. And you'll also notice that I'll have a habit of speaking to the floor rather than you. And the reason is that you distract me. And always my cognitive focus was on what I wanted to say, and then the speaking actually was just, it happened. And now I have to simultaneously think about speaking as well as what and so if I look at the floor, I'm not distracted. So it's not that I suddenly became shy. It's just, so I apologize for that. But it turns out that although it appears as you described that historically we have thought that better quality, lower cost healthcare is not attainable. Actually, this problem that the products or services of an industry at one point are very complicated and very costly, so that only a few have access to them, and then become affordable and simple, accessible to many. This occurs in every industry. There's nothing unique about healthcare. It's just not progressed as far as it needs to go in healthcare. But this is the challenge. You know, at the time when Reagan was president, was when America made a commitment that everybody could have access to health care. And then it's been stuck. And making it available to everyone is the first step, but then making it affordable is the most important thing. Because it's not plausible that everybody could be wealthy enough that they could afford health care as it is currently served, but rather it has to become affordable. So that's what I want to address. So you can characterize the history of almost every industry as a set of concentric circles, where at the center, what that represents are the customers in the industry who have lots of money and lots of skill. And then as you move out to these larger circles, they represent larger populations who have less money and less skill. And this is where, at the periphery, most of us live our lives. So in the history of computing, as in most histories, they start before there is sophisticated technology at the periphery, where we run into problems and we solve them in simple ways. So in computing, when I was in college, I just carried my slide rule everywhere. If I needed to compute, I just whipped it out, did the estimation, and got on with life. In that industry, as in most, the advent of sophisticated technology drove a centralization of the industry, because that first manifestation is so complicated and expensive that only people with a lot of money and a lot of skill can own and use it. And so the mainframe cost $2 to $3 million. It took years to be trained to operate them, so only the largest universities and the largest corporations could have one. We then had to take our problem to the center where the experts solved the problem for us. And that was better than the slide rule, but the limited access started to initiate a cascade of decentralization. So the first step, and those of you with gray hair will remember this one, was a step that we called a mini computer. We called them minis because the mainframe filled a whole room. The mini computer was about the size of that podium. It cost $200,000 rather than $2 million. But this enabled a larger population of people that we today refer to as engineers. They could have one in their office, in their department. And at the beginning, these mini computers could only do the simplest of the things. They had to take the complicated ones to the mainframe where the experts solved it for us. But oh my gosh, that mini computer just got better and better and better, so that over the course of a few years, you could solve more and more sophisticated problems in your own local computer, and you just didn't have to go to the mainframe asking the experts there to solve it for us. Then the next step was the desktop. And if you remember those, man, they were very simple. All you could do is word processing and build it simple spreadsheets. We had to take the complicated ones to the minis or the mainframes where those with more expertise solved the problems for us. But again, it was just remarkable how that desktop got better and better and better, so that even a poor fool like Clayton Christensen could own a computer, cost $2,000 instead of $200,000 or $2 million, and I could start to do pretty sophisticated computing without becoming smart. It just happened to me. Then, as you remember, the laptop came along, and for a long time we had to have two. That one in the office, where we did the serious computing, here when we traveled. But oh my gosh, this has gotten so good that most of us don't even need that anymore. And then the smartphone makes computing right in our pocket or our purse, where we can do computing wherever we want and solve problems on that venue that formerly a mainframe couldn't solve. And so it ended up where it began, where we can compute where we run into the problems. But the distance between 2 points in this case is not a straight line. Almost always it goes through this pattern. When I was a little guy, our doctor made house calls. So the solution came to the problem. But in this industry, as in most, the advent of sophisticated technology, for many reasons, drove a centralization of healthcare. And I've just listed here 3 types of technologies that mandated centralization because of the scale inherent with those types of technologies. And that meant that we then had to take the problem to the center where the experts would solve the problem for us. So as we looked at this through the lens of our research on disruption, which is the process by which complicated things become simple and expensive ones become affordable. I was on the board of the Brigham and Women's Hospital for several years in the committee that had responsibility for strategy. And we asked a member of our staff to study who was at the Brigham. And we concluded that about 70% of the patients in the Brigham today, 30 years ago, would have been in the intensive care unit. And about 70% of the patients in our ICU today would have been dead 30 years ago. And these institutions had become extraordinarily capable of doing remarkable things. But then the question was, geez, I wonder if healthcare will become affordable and accessible by praying and fasting that the hospitals will become cheap. It just isn't going to happen. Or that the doctors who practice there will voluntarily accept pay cuts. It just doesn't. Rather, what we have to do is to bring technology to outpatient clinics so that we can begin doing there the simplest of the things that today we have to address in a hospital. But then we have to drive technology into that venue so that over time they can do more and more sophisticated things, and so that you don't have to take as many problems to the experts, where the center where the experts solve it in that venue. And then we need to bring technology to doctors' offices so that we begin to do there the simplest of the things that today require a clinic. And then we have to keep driving technology into that venue so that you can do more sophisticated things. And in the same way, bring technology to patients' homes so that you can do there the simplest of the things that now you have to take to the office. But then you have to keep driving the technology so that they can do more and more sophisticated things. And in a similar way, rather than hoping that the doctors will take pay cuts, what we need instead is to drive technology into the practices of the primary care doctors so that they can begin doing in their venue the simplest of the things that today they have to refer to a more expensive specialist. But then we have to keep driving the technology into her practice so that she can do ever more sophisticated things. And in the same way, we need to bring technology to nurse practitioners and pharmacists, and ultimately to the patients and their families themselves, so that they can begin doing the simplest of the things that now they have to refer to someone who is more costly, and then keep driving the technology so that they can do better and better things. So in other words, how does healthcare become affordable and accessible? It's not by expecting the expensive ones to become cheap, but rather we need to bring technology that enables lower cost venues of care and lower cost caregivers to do more sophisticated things. That's the mechanism by which it becomes affordable and accessible. And so if there's one thing that you remember from your hour with me, it would be this. This is the way it always happens. I believe this is the way it needs to happen here. Now, I had a couple of stories I thought I'd tell you just to frame what I think that, at a high level, the challenge is going to be. So one day, it's like almost everything that's ever happened to me. I was in my office just doing my business, and somebody calls. So I was just minding my own business, and Andy Grove called me, who was the chairman of Intel at the time. And he said, truly, he's quite a gruff man. He said, look, I'm a businessman. I don't have time to read academic drivel from academics like you. But somebody in my organization read some academic piece that you wrote that predicts that Intel is going to be killed. And it turned out there was nothing in the article about Intel. I'd never thought about Intel before. But it was, in fact, an article about what kills successful companies is people who come in at the bottom. Anyway, Grove said, look, whatever it is, I've got a meeting in 2 weeks. I'd like you to come out. I'll give you 30 minutes. And I want you to explain why you think Intel is going to be killed. So for me, it was a chance in a lifetime. So I show up there, and as I walked in his gruff voice, he said, look, stuff's happened. We got no time for you. But look, I'll give you 10 minutes, and I just want you to tell us what it means for Intel. And I said, Andy, the problem is I don't have an opinion about Intel, but the theory has an opinion. And I can't say anything about Intel until I've described this theory, a disruption. So nobody ever said to him that a theory has an opinion about him. So he sat back impatiently, and he said, I got to describe this theory of disruption. 10 minutes into it, he chopped me off, and he said, look, I got your stupid theory. Tell me what it means. And he got what he got, and he really did get it. Then I said, Andy, I just can't do it yet because I've got to describe how this process of disruption worked in a completely different industry than yours, just so you can visualize it. And then let's think about Intel. So I picked an industry that's just totally different than microprocessors, which was steel. And I described how these companies called mini mills had come in at the bottom of the market and picked off rebar and then moved their ability to make ever more sophisticated products until all but one of the big integrated steel companies like Bethlehem Steel had gone bankrupt. And these guys from the bottom to the top had grown, so they accounted for about 60% of North America's steel production. Anyway, when I was done with that, Grove said, ooh, I get what you're saying about Intel. And he went down and he said, we have two companies like that, Cyrix and AMD, that are coming at us from the low end, starting at rebar. And they're going to kill us, aren't they? And I said, well, that's what the theory says. And then he went like this, and he said, we got to go down and we got to kill him, don't we? And that was what they called the Celeron processor. And I thought about this a lot, because if I'd have been suckered into telling Andy Grove what he should think about Intel, I'd have been killed. But rather than telling him what to think, I taught him how to think. And it was so clear to him that he thought I had told him, and I didn't. So whenever somebody approaches me with the challenge, I never tell them what they should think, but rather I try to build upon some model in my mind to teach them how to think, and then almost always they say, oh, I get it. Anyway, I was then interested that Andy Grove did not stand up in front of the company and announce, ladies and gentlemen, we're going to the bottom of the market, because it was just so counter to the profit logic of the company. And so he set up a seminar where he brought in 100 people at a time. It lasted a whole day. And he did it 20 times over the course of a year. So about 2,000 of his senior people. And spent a whole day on this model of disruption. Present a little bit, have breakout groups to discuss, are these guys really going to kill us? A little bit more breakout groups to discuss how could we use disruption to kill other companies. And present a little bit more to have breakout groups to discuss how Intel has to reorganize itself. Anyway, last year Intel shipped about $25 billion of products that emerged from these breakout groups. And so I was talking to Grove about it a while ago, how he pulled all this off. And he said, you know, having a theory doesn't give us any answers, but it gave us a common language and a common way to frame the problem so that we could reach consensus around a counterintuitive course of action. And I just thought that was brilliant. And when I watch what's going on in Washington on healthcare or in the state capitals, this is their problem. They don't have a common language. They don't have a common way to frame the problem. And they start their discussions around what should we do. But without the investment that Andy Grove made, there is absolutely no way that we can solve the problem. Understanding, giving a language and a common way to frame the problem is critical. And I'm hoping that our framing it in a plausible way can contribute to that solution. And I thought that I would just give one example of this here, and then I want to go into some more other dimensions of our work. So just last month, I was invited to a meeting of an association of associations associated with the pharmacist. And so this is the group, the Association of Pharmacists, but there's also a association of pharmacies, and there's another association of universities that teach pharmacists, and so on. And there are about 10 of them, actually. And those guys, of course, are all going to Washington and adding to the problem, because when they propose something, they use self-serving language and self-serving data. And everybody goes with self-serving data and self-serving language. And it really causes the members of Congress, it's like in the Old Testament, do you remember when these guys tried to build this tower to heaven called the Tower of Babel, and it ticked God off so much that he gave everybody different languages so that they couldn't work together. And if you're a member of Congress, it's like you're sitting at the base of the Tower of Babel, because everybody's going after with different language rather than a common language. Anyway, so I was talking to these guys about this, and in many ways, it's what we're saying is we need to give these people more and more sophisticated capabilities so they can take on more and more responsibility. And they said, it's nice for you to say as an academic, but let me tell you what life is like. We are trained with master's degrees. We can do almost everything that those guys can do, and they won't let us do it. Instead, we spend 80% of our time counting pills after with a master's degree. And man, they're frustrated at how life has turned out. Well, then, it turns out, at roughly the same time, I got invited to give a talk at the Vanderbilt School of Nursing. Ooh, these guys are mad about life, because their graduates can do almost all of the things that these people could do, but these guys, you know, are territorial, what do you know? and won't let them do it. And then I talk a bunch of these guys, and their life, they feel like life is coming to an end because they can't go, they have the ability to do what many of the specialties do, but they're so obsessed with not letting them do it that there's almost no role in the future for the family doctor. And so they're all frustrated about the same problem. If you go to get a new prescription for your eyes, talk to the pharmacists, and they think, why in the world do people have to go to the ophthalmologist? Because I got the machine right here. I can do it all. But of course, so they all have the same problem, and that is they want to go up market, to take their expertise to do more and more sophisticated things, but instead they all think they have a unique problem. So what we're going to try to do this summer is convene an association of the associations of the associations. All of these people, and say, ladies and gentlemen, you all have exactly the same problem. And we need to not ask for our share of the pie, but rather together go to Washington and understand that we all agree on the solution. Anyway, we'll see how we do. I wanted to go into the question of when disruption occurs that enables people with lower cost providers to do more sophisticated things, what has to fall into place? And there are three things. One of them is the structure of the industry itself has to change. In other words, there are some problems which are impossible to solve unless you change the industry within which the issues are addressed. And so I'll go there next. And then second, I want to talk about the changing, the technology that makes it simple from a personal point of view. So this was an insight that we got watching Obamacare go through the birth process. And if you remember at the time, a big issue was on the left. Guys, just face reality. We need to have a one-payer, government-paid system. Because if you look at the Canadians and the Europeans and the Australians, it's a one-payer, government-paid, and they have so much more accessible access at the primary level. But when you go to Ottawa or Europe and you ask those guys, what are you thinking about? They're saying, man, our system is so broken. We need to go to the American system of multi-payer, private. And when you have that kind of a paradox, almost always it's because they got the categories wrong. And what we decided is, in fact, this notion of public versus private, single payer versus multi-payer systems is the wrong categorization scheme. But rather, you might find yourself in two different situations, which then mandate different structures of the industry. And in one situation, the industry structure that works is a situation where all the pieces fit together in clean ways. And a way to visualize that one is if you have at home a Dell computer, Hewlett-Packard, or Lenovo, get a really fine screwdriver and take the back off and just spend some time looking at what the computer is. And what you'll observe is it's just filled with components, each one of which was supplied by a different company. And then I want you to just kind of get mad at that computer and say, I'm sick of this. I want you to just rethink the concept of a computer. Because I've had, this concept of a computer for the last 30 years, and it's time for change. So you would then ask representatives from each of these the component suppliers into a room and say, the reason I brought you here is I want you to rethink a computer. What will then happen is that the representative from Intel will stand up and say, well, I'll give you more gigahertz on your processor. The person from NVIDIA will say, and I'll give you more graphics. And the one from Windows would say, we'll give you Windows 8. And the next one, I'm from Seagate, I'll give you more terabytes on the drive. And you say, no, that's not what I want. I want you to rethink the computer. They can't do it. Because all they can do is they have responsibility for one piece of the system, but there is nobody in the group that can put their arms around the whole problem and rethink what roles each of the components need to play. But this, I'll call it a Dell system, actually works when you know exactly how the pieces of the pieces fit together, and as long as you're happy with the performance of that architecture. If you have an Apple iPhone or iTablet, get a really, really fine screwdriver and very carefully take the covers off. And if you look inside, at one level, yeah, it's comprised of components too. But if you crawl inside and pull the components apart, what you'll see is something totally different. And that is the design of every one of the components was interdependently designed with all of the other components. And if you took out one piece, they couldn't have done any of the other pieces because the interdependency was so intricate. And if you brought together a group of people from Apple and said, could you guys please just rethink the concept of a computer? They would say, you're kidding me. We've done it 3 times in the last 10 years. You need another one? And in a situation where there are so many interdependencies, you need to have an industry organization or structure where the people responsible actually have the scope to wrap their arms around the whole system problem rather than the components problem. And so it turns out that about 90% of Americans receive health care in a Dell kind of a system, where the insurance companies are independent of the hospitals, which are independent of the doctors who are largely entrepreneurs themselves. And just as an example of how that works for us, with just a few months of training, nurse practitioners or physician assistants could do almost all of the colonoscopies in America with perfect accuracy. Because the ability to do it is resonant in the equipment and the processes involved. But in 90% of America, you can't let her do it because they can't get reimbursed. And the reason why the insurance companies can't reimburse is that she's not licensed to do this. And it was doctors that define whether or not you're licensed to do that or not. And the doctor will say, look, they can't do that. They're not qualified. It's got to be left in the hand of the doctor. But let me tell you, I could do it in my office in a heartbeat. And the hospital would say, over my dead body, can you do it somewhere? You got to do it in a hospital for the sake of the patient. And so they can't move. Because to make sense, for one person to make sense, you have to agree from all of the people for whom they don't want it to happen. And so nothing works. And it turns out that, Canada's organization is just like a Dell Computer 2. The government pays the checks, but the people responsible for the hospitals are different than the people who enroll or employ the doctors and so on. And Germany and the Netherlands are headed very dramatically towards this kind of a Dell-type system. The way an Apple-type system is organized is in an interdependent way. They can wrap their arms around the whole thing. And about 10% of America is covered with Kaiser Permanente. Intermountain is kind of a hybrid Geisinger in eastern Pennsylvania. And Sweden and Finland are organized like this. And in that kind of a system, if you say, look, why don't you get the nurse practitioners to do colonoscopies? What Kaiser Permanente will say is, geez, we decided to do that 10 years ago, and it works great. And they can make the decision because there isn't somebody like an insurance company out there that is able to say yes and no. If it makes sense that those decisions are made inside with the system's perspective. So that's the first, it's an assertion that I would make that, again, if we fasted and prayed, the second coming will come and go, and this system will not have provided any significant change because the system itself is incapable of making systemic changes. And so to really make what has to happen, we really need to move people in this direction of an interdependent, integrated system. And what it means in Boston is Harvard needs to own an insurance business that they don't keep separate, but is just inside. One last thing about this. So, Kaiser Permanente, there's a technology that you can seal children's teeth. You know, it's been around for 25 years or so. Very proven, very safe. 100% of the children who are covered as members of Kaiser Permanente, the children have their teeth sealed. And what it does is you have no cavities. In the population in California not covered by Kaiser Permanente, only 1/3 of the children have their teeth sealed. And the difference is that in an integrated organization like Kaiser, a cavity is a cost. On the outside, a cavity is a revenue opportunity. And this system, because of the way it's integrated, they make their money by keeping people well. And so you could call it a healthcare system. In the other ones, you would characterize it as a sick system because they make money when people are sick. And it's actually really important that people be sick. So downtown in Children's Hospital is a marvelous hospital. They announced last year the results of a long study for a new procedure when children come to the emergency room with asthma. The procedure was quite different, and as a result, it cut down the overnight stays with children with asthma problems by 80%. It was really a wonderful thing for everybody except children's. And the next meeting of the senior management, the number one item on the agenda was, how are we going to fill the beds? Because it's in a system where that's just required. Okay, so the next thing is I assert that providers, lower cost providers can do progressively more sophisticated things. This is my sense for how that can happen. And again, by analogy, 80 years ago, if you wanted to have a new molecule from which you could spin synthetic fibers, there were only about 50 people in the whole world who could build these molecules, and DuPont employed almost all of them. And the way those artists practiced the craft was they would just reach down and pull up all of their education and experience and intuition and pour a bunch of atoms in a beaker, heat it, stir it, draw out a fiber, look at it under a microscope, go down the hall, knock on a colleague's door, and say, do you think I've invented anything here? And she'd say, I have no idea, but bring it in, let's heat it up for 10 more minutes and see what happens. And the miracles that we call nylon, polyester acetate, and Kevlar emerged from the labs at DuPont through what was essentially a trial and error process. And you had to be the best in the world to play in the game. But as those artists practiced the craft, patterns began to emerge. And as organic chemistry moved into a pattern recognition realm, you could teach other people how to build these molecules. There's no cookbook yet, but there were patterns. And you could express the outcomes of an action in probabilistic terms. And that meant that you didn't have to be the smartest in the world. You just had to be reasonably good to play in the game. So a lot more companies got into the business of synthetic fibers. Then there were a few theories that came to be better understood and applied, like quantum theory and rate theory. And these theories, which were statements of what causes what and why, as they became better understood and applied, people could build software models so that you could know in advance, before you started, whether a particular type of molecule could or could not be built. And before you even made a molecule, you could know in advance what its properties will and will not be. And so today, you really just need to have a bachelor's degree in chemie from an average state school and a great piece of software. You can build much better quality molecules faster and at lower cost than the world's experts did a generation ago. And so before you go to bed tonight, seriously do this. Stand up, turn around 360 degrees. You'll be able to put your fingers or your eyes on 10 to 12 fibers in your room that have just proven to be an unmitigated blessing in our lives in terms of their low cost, durability, flexibility, appearance. But this blessing has not come to mankind by replicating the expertise of DuPont scientists, but rather commoditizing their expertise through scientific progress. And we have the same problem in healthcare. Historically, almost all care was addressed in what we call the realm of intuitive medicine. And for whatever reason, when they organized the world, somebody miscounted. And what I mean by that is our vocabulary, the vocabulary of our body that it can draw upon to express that something has gone wrong is very limited. And the body's vocabulary are symptoms. And the problem is that there aren't enough symptoms to go around for all the diseases that exist. And so the diseases had to get together and agree to share symptoms. And this is the fundamental problem. Because, like, we thought that type 2 diabetes is a disease. It's not a disease. Elevated levels of blood glucose is a symptom that is shared by about 22 different diseases. And so if I'm a physician and somebody presents herself to me and I see the symptoms and I think, I saw somebody just like you 2 weeks ago. I gave her that. It solved it. I'm going to give it to you. And it doesn't work. And we realize now that the problem is when we identify the diseases, the symptom, it is very unpredictable. And therefore, there can't be rules. You just have to have the best in the world just pull down and pull out their intuition to treat each person differently, because that's the way the world appears. But as they practice their craft, patterns begin to emerge. And we call this one empirical medicine. Others will say evidence-based medicine. We decided to call it this because the evidence is never clear. But this allows you to express probabilistically what will happen to a population. And so some of you know I'm being treated for follicular lymphoma. And when it was first diagnosed, the doctor, they biopsied one of the tumors and then showed it to me in a slide. And he said, there are roughly 37 different types of lymphoma. And look at this one. Can you see this one, number 23? That's what I think you have. Now we got two options. This course of chemotherapy, there's a probability 5 years from now, a 73% probability that you'll still be in remission. If we take this new one, the probability that you'll be in remission in 5 years, somewhere around 86%, it's less, it's not pleasant, but that's what we should do. And so he couldn't say anything about clay, but he could say something probabilistically about the population. But then as science continues to progress and theories of cause and effect became clearer and clearer, it moves us into a realm of precision medicine. We call the world precision because if we diagnose precisely what causes it, then it brings the probability that we could develop a predictively effective therapy for it. And this movement from that side to this side is what enables us to say that we can, over time, technology will enable us to do lower cost venues of care and lower cost caregivers to do progressively more sophisticated things. It's because we go across this. And I've described it as 3 discrete events. In reality, it's disease by disease, step by step, year by year, moving from the right hand to the left. And the challenge is that as it moves this way, if the system causes the providers who addressed it here, but now the technology is here, they don't want to hand it off to somebody, then the progress of technology has no impact. And that's really where we are today. And it's why it's moved here, and the pharmacists and the nurses and the primary care doctors are so frustrated because as it's moved here, they can actually do it, but the system won't allow it. Are you doing okay? I just want to do a couple of thoughts about hospitals. And the bottom line is that hospitals are not viable. That in the absence of philanthropy and constraints on trade, almost all hospitals would collapse. And so I'll show this as quickly as I can, and then you can shoot cannonballs. So those of you who have suffered from some of my courses might remember a company called Michigan Manufacturing Company that makes axles. They have 9 plants. The one of interest is in Pontiac, Michigan, that is organized like this. And this one is known in the company for 2 good and bad things. One is the proposition that the Pontiac plant makes to the world is, I don't care what you want me to do, bring it here. We can make any product for anybody. And the downside of that is it's a very expensive plant. So for every dollar that's spent in direct cost making these axles, there is $6.2 of overhead. It's a very costly plant. And this is our sense for why it's organized by the type of technology. And the reason why they organize it by technology is that the equipment is very expensive, and it's very, the workers are very skilled at their work. And so you optimize the use of the machines and the operators if you organize it this way. But the greatest thing about it is this organization can make any product for anybody. So a customer will bring a design of an axle, and the manufacturing engineer will look at it and say, you know, I think we better cut it to length. Then we ought to put it on the lathe to turn it to the outside diameter. Then I think we ought to take it to the hobbing department to cut the gears in it. And when you do that, the steel gets mad. And so we have to put it in a furnace to just make it relax. And after that, let's drill the holes in it, put in the screw tappings, deburr it. Because of that, let's assemble it, take it over there a bunch of different times. Finally, you polish it, and then you ship it. When the next customer comes with a different design, they do it again, and it just is a mismatch of every company following a different path through the system. But the neat thing is they can make any product for anybody. There was another plant in the system where the overhead wasn't $2.2 of overhead per dollar of direct, but it was actually only $2.2. So the overhead was a third of what was generated in the Pontiac plant. This is in southern Ohio. And when you look there, you realize what had happened is the low-cost plant didn't say we will solve any problem for anybody, but rather 15 years earlier, they had taken a pathway that was the most common pathway that customers' products followed as they went through the plant. And they took those pathways, which is a sequence of activities, and they lifted it up like a snake and carefully took it down to southern Ohio and stretched it out as a straight line, just a sequence of activities. And their proposition to the public was, we actually won't make any product for anybody, but if you happen to design your axle so that it can be made by one of these 2 sequences, holy cow, can we do it at low cost and very high quality. And as we studied this problem more, we realized that, or we calculated that every time you doubled the number of pathways that products were taking through one of their factories, when you went from 1 to 2 pathways, 2 to 4, 4 to 8, and so on, it increased the overhead cost by 30%. So, and that explained why Pontiac was so costly, is because they said, we will do anything for anybody. And as a consequence, it was just a mishmash, and the complexity drove the overheads. Now, if I could erase the types of the equipment, and I just showed you this, and I said, is this a schematic of a axle factory or a hospital? What would you say? It's the same thing, right? For exactly the same reason, that in a hospital, out on the side of the hospital, they announce, I actually don't care what's wrong with you, bring it here. We can solve any problem for anybody. And as a consequence, the pathways that each patient takes through the plant is typically unique. And because of that, 85 to 90% of the cost in a hospital is overhead cost that is associated with this proposition that we can do anything for anybody. What makes it worse is that there are 3 fundamentally different types of business models in the world. They're incompatible with each other, and they all exist inside of a hospital. So one type of business model we call a solution shop. And a solution shop is a business that defines your problems and recommends solutions. So McKinsey, Bain, BCG are solution shops. The activities in a hospital where you diagnose and recommend solutions for diseases that are in the realm of intuitive medicine are solution shops. And almost always, those kind of business has to be compensated on a fee-for-service basis. And by a description of solution shop, this guy is a good friend of ours who's been the CEO of Medco. The poor guy has suffered from asthma his whole life. And asthma is in the realm of intuitive medicine. Wheezing is a symptom shared by at least 8 different types of disease. Poor Dave has seen dozens of specialists in his life, and in his language, they had added to, subtracted from, or multiplied the number of drugs he was taking. At one point, he was making taking more than $1,000 of drugs a month, and nothing helped. And he read what we were thinking about here, and he realized that there was this outfit in Denver called the National Jewish Medical Center that is a solution shop for pulmonary and respiratory diseases. And so we just flew out there. And on the first day, they gave a standard body of tests. On the second day, they sat him in a room, and in walked 4 different specialists from very different areas than he'd ever thought about before. And they started to argue and looked at the data, argued some more, asked Dave a bunch of questions, argued some more. And after about 30 minutes, the leader said, Dave, I think we figured out what's wrong. The reason why none of those drugs has ever worked is you don't have any one of those types of asthma. You got this type, and it's your lucky day. There's just a generic drug that's going to solve the problem. And so we want to have you stay here for another day, and we're just going to stress test you. But we're quite certain that that will solve it, and it did. And he had a couple of observations. Interestingly, he had seen those types of specialists many times over his life, but he always had seen them singly. This is the first time they'd ever converged. And he realized the reason is that in order to keep the flexibility of doing anything for anybody, the hospital doesn't have a mechanism to converge people from different perspectives at the problem. And then the second question he asked was, I wonder if it was cheap or expensive to to fly to Denver to get a good diagnosis. It was dirt cheap. But that's what we mean by a solution shop. Then another business is a process business, where you bring things in that are not complete, you do stuff to them, and then you ship them out the door. And manufacturing is like that, but the Harvard Business School is like that. We bring in incomplete people every fall, and then we do stuff to them every day, and after 2 years we ship them perfected to Wall Street. And medical procedures, after a definitive diagnosis has been made, is like this. And those guys make money on a fee-for-outcome basis, because the ability to predictively predict what will happen is embedded in process and equipment. And some of you have seen this in the Shouldes Hospital north of Toronto. They have just one pathway through that factory. And this is what the economics look like. In a typical hospital, there are 110 pathways. This has one, because all they do is hernia repair. The cost, the direct cost is similar, but look at the difference in the overhead that's associated with the complexity here. And so the cost of doing this is 35% of the cost there, and it's all in the overhead. And so really what needs to happen to our hospitals is you need a few mass generals, but over time they need to separate themselves into solution shops where they make money on a fee for service, and process business where they make fee for outcome. And there's a third type that I scanned over that's called a facilitated network, where the model is a free fee for membership. But if you are asked to be the president of a hospital, it's kind of like you preside over an entity that was created by merging Bain & Company with Whirlpool's manufacturing operations and acquired Northwest Mutual Life. And you try to integrate them all together and express your income statement and balance sheet as an entity and measure quality on the same metrics. And it's just not a viable concept. And so we'll do better if we cut them apart. You're very patient to waste your time with me, but I hope it's been useful in some way. Thanks.